Obesity is one of the most modifiable risk factors for cancer, yet its role remains underintegrated in routine oncology and prevention strategies. While tobacco cessation and genetic screening are well-established pillars of cancer risk management, obesity often lingers on the margins, acknowledged but rarely acted upon with the same clinical urgency. This oversight may be one of the most significant blind spots in modern cancer control. As the global burden of obesity continues to rise and cancer incidence follows suit, it's time to confront a critical question. Should obesity screening be incorporated directly into cancer prevention protocols and oncology care? For years, body mass index, BMI, has been used primarily as a general indicator of metabolic risk, flagging individuals at higher likelihood for diabetes, hypertension, and cardiovascular disease. However, a growing body of evidence clearly links excess adiposity to at least 13 types of cancer, including postmenopausal breast, endometrial, colorectal, kidney, pancreatic, liver, and esophageal adenocarcinoma. The relationship is not merely correlative but increasingly understood to be causal, driven by a cascade of biological processes such as insulin resistance, chronic low-grade inflammation, altered sex hormone levels, and changes in immune surveillance. In some cancers, obesity rivals or exceeds smoking in attributable risk. Yet, this connection has not translated into routine practice. Most oncology clinics do not assess or intervene on obesity as part of standard cancer risk reduction or treatment planning. Patients are often not counseled on weight loss as a means of lowering recurrence risk, and obesity is rarely factored into screening algorithms or survivorship guidelines. Meanwhile, patients with obesity may develop cancers earlier, receive diagnoses later, and face worse prognosis due to both biological and clinical barriers. This disconnect raises a difficult but necessary question. Why isn't obesity treated as aggressively as other carcinogenic exposures? One reason is the persistent controversy surrounding BMI itself. Critics argue that it oversimplifies health status, fails to distinguish between fat and muscle, and can stigmatize individuals without necessarily improving outcomes. These are valid concerns. But rejecting BMI entirely risks throwing away a useful, if imperfect, tool that can identify at-risk individuals before cancer strikes. Like cholesterol for heart disease or blood pressure for stroke, BMI and body composition measurements can serve as screening markers to flag those who may benefit from deeper evaluation and preventive interventions. Beyond BMI, more precise tools are emerging. Waist circumference, visceral fat imaging, metabolic panels, and inflammation biomarkers such as CRP and IL-6 offer a more nuanced view of how obesity contributes to cancer risk. Integrating these indicators into oncology risk models could help identify patients who might otherwise be overlooked under traditional paradigms. For example, a postmenopausal woman with high visceral fat and elevated estrogen levels might warrant earlier or more frequent breast cancer screening, even if her BMI is only modestly elevated. Incorporating obesity assessment into cancer prevention would not only improve individual care, but also enhance public health strategies. Current cancer screening guidelines such as mammography, colonoscopy, and HPV testing are largely age-based. But age alone does not capture the biological risk profiles driven by modifiable lifestyle factors like weight. Layering obesity into these guidelines could refine screening windows, prompt earlier diagnostics, and catch tumors at more treatable stages. Importantly, this shift would also help dismantle a false dichotomy that separates obesity care from oncology. Too often, weight management is siloed within primary care or endocrinology, while cancer prevention is considered the domain of genetics and imaging. In reality, they are deeply intertwined. A patient referred for genetic counseling due to family history of breast cancer but also carrying significant excess body fat should receive comprehensive education about how both inherited and acquired risks interact and what can be done to reduce them. This rethinking should extend into survivorship as well. Weight gain is common after cancer treatment, especially in breast and endometrial cancer survivors, yet few survivorship programs offer structured obesity interventions. This omission ignores the growing evidence that weight loss post-treatment can reduce the risk of recurrence and improve quality of life. If we fail to address obesity in survivorship, we are missing a powerful opportunity to prevent second cancers or late metastases. Of course, integrating obesity into cancer prevention is not without challenges. It requires system-level changes, updating clinical guidelines, training oncologists in lifestyle medicine, improving insurance coverage for weight loss therapies, and countering stigma that may discourage patients from seeking help. But these are solvable problems, and the alternative is to allow a known carcinogenic condition to continue unchecked in clinical care. Cancer is a disease of complex origins, but many of its drivers are within our power to modify. Tobacco use has declined sharply due to decades of aggressive prevention, regulation, and early intervention. Obesity deserves the same level of systematic attention. By moving from BMI to biopsy, not in a literal sense, but in rethinking how we trace and treat cancer risk, we can close a dangerous gap in prevention and give patients the full range of tools they need to reduce their cancer burden. Obesity must be recognized not just as a comorbidity, but as a cancer risk factor in its own right. And that recognition must be reflected in how we screen, counsel, and treat, from primary care to oncology to survivorship. The science is clear. Now the question is whether our healthcare systems are ready to act on it.